Welcome, everyone. This is a series of rounds. My name is Harsh Shundle. I'm the Executive Medical Director for Physician Engagement. And these rounds were created in conjunction with the Canadian Medical Association to look at ideas and concepts that hopefully will drive change and that are important in terms of how we develop as a resilient and sustainable health system in the long run. These rounds are accredited through UBC, and at the end of the rounds there will be a slide in which you can click on with your iPhone in order to enter in for your UBC credits, as well as an email address. So to begin, I'd like to acknowledge that we are meeting on the traditional territories of the First Nations peoples. I am in the interior region in the Okanagan-Silik. There are 7 nations in the interior, and we know we have people connecting from across British Columbia for these rounds. These are the lands in which we live, work, collaborate, and play, and have an obligation of stewardship towards the people and the environment. I will now review our agenda in terms of information and privacy, etc. Next slide, please. So the exchange sessions will be recorded and shared publicly. Presenter and facilitator names will be shared. Your names as attendees will not be published, though your voices will be recorded on the question and answer portions. And those who are attending will be able to apply for CME or CPD credits. Next slide, please. These are the tips for Zoom. Now you will notice at the bottom of your screen is a chat function. If you wish to ask questions, please feel free to use the chat or to comment. But we encourage people to interact using chat. It's amazing the conversations that can go on. For those on telephone connection, if you hit *9, you'll get through to Laura. There's Laura and Colleen who kindly are supporting us this evening. So if you hit *9, you'll be able to ask a question. And for those on telephone only, *6 to mute, *6 to unmute. Next slide, please. So our topic today is physician stress, illness, and impairment, enhancing resilience. And our presenter today, our person we're going to have a conversation with is Dr. Derek Puddester, Deputy Registrar from the College of Physicians and Surgeons. Derek grew up on the other coast, one of the other coasts, the Atlantic coast. He's been quite involved in the whole area of the occupational stresses in medicine, and was involved in Ottawa, and Derek will introduce himself. And by training, he is a psychiatrist, so naturally the effects of organizations, life, etc., he's supremely interested in. So, Derek, I'll turn this over to you. And I'd like to, first of all, just say one thing, and that is that we're focusing on resilience as opposed to burnout. And the reason for that is that we focused on burnout and what goes wrong. But the thing is that resilience is what gets you through. And as Darwin said, the theory of evolution is not about the survival of the strongest, but the survival of those who are most resilient and adaptable. So there you go. You get an introduction from Darwin himself. Go ahead, Derek.
Thank you. Thank you very much. I just want to make sure I've done the screen sharing right. Is that looking good on your end?
Excellent.
Awesome. Perfect. Well, hey everybody. It's nice to connect in these interesting times. I so look forward to the day when we can all be back together and looking at each other and being able to sit within 6 feet and talk and have coffee and talk about these issues. We will get there. We will get there. But thanks for showing up today. And our sort of my hope in joining your community for this exchange is to try to keep this as conversational as possible. So, I mean, we have some material on slides, but sharing the slides isn't the goal. The goal is to sort of share some ideas and hear from the community and do some just joyful time together. So a couple of things to go through. Okay, how's that? That one work? All right. So I just want to acknowledge that that the college where I'm at today, we're on the unceded territory of the coastal Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh peoples. When I think about resiliency, I mean, is there? There's so many things that we can unpack with a slide like this. I come from Newfoundland, where you know, talking about work in truth and reconciliation is very complicated, given our history with the Beothuk people who I acknowledge that my people slaughtered. It is quite powerful for me to come to be part of a new community, to be a guest on lands where the peoples are still very much alive and very much vibrant, and so willing to teach and engage and welcome. I take that very seriously, and I'm very grateful for it. In terms of disclosures, really none to declare other than the college supports our time together today. So a couple of things we could talk about. I brought a couple of things about constructs of resiliency. There's some models of resiliency that really have been developed in other professional sectors that I just think are worth us knowing about. I wanted to give a little nod towards moral injury. And then we can have a conversation about resources from everything across the spectrum, from, you know, when we're stuck and we need help, you know, when we're thinking about contacting the physician health program in BC, all the way over to things that I think are really quite important and powerful. And it's how do we build a system, perhaps rebuild or rejig a system that really helps us all thrive and be resilient in the face of tremendous challenge. So hopefully we'll talk about some of those things too. I am here today, though, wearing the hat of the college. And of course, we do lots of things, and I'm sure this is familiar to most of you. I'm fairly new to the college, so for the community who I haven't had a chance to meet, I come from Ontario, where most of my work was in the Department of Child Psychiatry at the University of Ottawa, so I did hospital-based work. And a lot of my other work was in professional health, so I did a lot of work in the area of physician health, you know, treating my colleagues, advocating for colleagues, building programs for colleagues. And just before I came out to British Columbia, I was doing some work with the military in their training group at Royal Military College, and really quite enjoyed that work. It taught me a lot about resiliency in a different community. The college is, of course, a creature of statute. So the things that I tend to come across in my work now as the Deputy Registrar for Complaints and Practice Investigations is often bound, you know, by the statute. But we're having lots of interesting discussions about what does that mean? Where might the statute go? How can we bring evidence-based regulation from other jurisdictions into our work? And we're currently doing a lot of work looking at the humanization of complaint processes from the perspective, most importantly, of the patient, but also from us as physicians. How can we make this process more humane for everybody? And a sense that it's meaningful and really does help achieve what complainants are looking for. So we've got lots of work to do, and I acknowledge that too. And we're also mindful of our times. I've already given a bit of a tangential nod to the fact that we're already resilient. I mean, look at us all. We're in the middle of a pandemic. You know, we've got our colleague, Dr. Henry, telling us about second wave, and I'm very mindful that people have been out there on the front lines taking care of really sick people in very stressful moments. So I'm just very mindful of that. So a couple of things just broadly about resiliency. This has been a discussion in our discipline for almost 20 years. I'm sure it goes back further, but you know, when I think of the first time we at a national level started to talk about physician health and resiliency, I was a medical student. And I remember going to some of our national organizations with the research we had done as medical students, and in a very blunt and directive way, we were really told to shut up. We were told that talking about physician health and wellness issues was dangerous. It could bring shame to the profession. I remember being at a national meeting with two very senior, highly skilled people, and they turned to me and they were very blunt. You know, how dare you? How dare you raise these issues? These are extremely private. And I suppose here we are, 20 odd years later, and thankfully we have gotten out from under that stigma, and we're able to talk about the value of a resilient and thriving physician population. And I think really the end goal is acknowledging that a healthy us means that we're able to provide better, safer clinical care. The CMPA has been doing work in this area for quite some time too. They've published this great definition of resilience, the ability of an individual to respond to stress in a healthy and adaptive way such that personal goals are achieved at minimal psychological and physical cost. So I think it's a very reasonable definition when we think about bouncing back. And there was a time when we were looking for data in physician health. How many people are really struggling and how many people are not. And of course, we'd have conversations about, well, why is that important? What does it mean? And the CMA has done wonderful research showing that about 82% of us report high degrees of resiliency. And to me, that makes sense. I think to think of all of the challenges that we would have had, normal life stuff as young people, getting us to a point that we get into medical training. And of course, all the challenges we experience in medical training. And then of course, all the challenges we experience when we're in training. To kind of go through a process like that, we often lean on resiliency. We know that there's some tension points in our community to be mindful of. I'm always very sensitive to the issues of what I call early career physicians. People in their first 5 years of practice. We know that's a real pinch point. So how do we as a community take the resilience that we've learned and developed over years and really help that group with that? And we also know that within our community that women often will report on instruments that the resiliency is slightly lower compared to men. And I certainly put out there that we've achieved a lot in gender parity over time, but I still continue to observe and hear and from colleagues that women still carry a high degree of burden of responsibility, not only professionally but personally, and we need to be mindful of that. There's been a lot of literature looking at how do we enhance resiliency, and as a child psychiatrist, we, in our literature, we often look at the outlier populations to learn how do we help those who are struggling, and so looking at success and what makes some people resilient and others not helps us extrapolate some things that can be helpful. Positive psychology as a field has been growing in awareness and evidence for about a decade and a half. Yale, by the way, offers a free online course in positive psychology, which I'd encourage anybody to check out. But authors like Howe talk about drilling down and looking at really practical things, social supports. So you can just take a moment and think about who in your community contributes to you being resilient. Who do you lean on? Who do you can lean on? What is that like for you? Managing negative emotions. And I think for leaders in medicine, making that transparent and role modeling, how do our leaders manage negative emotions can be quite liberating for other people who may still be struggling with that imposter syndrome. Am I the only person who feels like this? Or even worse, one day they're going to figure out I'm actually not competent. So role modeling management like that can be helpful, and really allowing people to have open and safe conversations about moral beliefs and how that ties into self-motivation can be really important. A couple of days ago, Harsh and I were having a call in advance of today's rounds. And, we were just thinking about our own relationships with resiliency, for us, what has been helpful. And Harsh, I'm going to pick on you for a minute, but you very quickly said hobbies. Hobbies have been very helpful, and it's certainly your story to tell, but I'm aware that you've leaned on hobbies and perhaps shifting your hobbies a bit to help with some challenges. And I also shared a great story about how I've developed some fun crafting hobbies just to help with those moments, when your kids are driving you crazy and work is really stressful, and there's a lot going on with your elderly parents, and you've got reports to get done and grants to write, and you know, I'm just going to go take an hour and work on a hobby and clear my head of all that. And just the act of giving ourselves permission to do that can build resiliency. There's also the notion of acknowledging that things are difficult. I think the pandemic has brought some awareness to normalizing that it's okay for us to say, you know, things actually aren't okay. These are not the new normal times. These are abnormal times, and we're all doing a job of sort of stretching and adapting and finding a way of making things work. And there's lots of challenges for us just as people in a very complex system. I've listed many of them. I think in medicine, we know now a lot about some of the individual factors that go into these challenges leading to illness and impairment. But I also think we're now really understanding at a systems level what goes into also feeding these and becoming, concerns about illness and impairment. I mean, I can just pull the thread of one. And when I think about, trauma, I think a lot of us can very quickly think back to things either in our pre-medical lives or our experience in training or practice that have been traumatic. And just thinking about how did we process that individually as a team, as an institution, as a community? How do we understand and acknowledge the impact trauma has on people? Particularly the system is also traumatizing for many of the people we try to serve. So I think that when we just acknowledge challenges, we bring them out to light, we put our cards on the table, we share our stories, the more that safety can be built, and we can think about where in this is their attention and meaningful change to reduce that. Over the years, there's been a lot of nomenclature in the area of physician health. Years ago, probably even before I was a medical student, my understanding of the literature was physician health really referred to colleagues who were living with substance use issues. And that really was the be-all and end-all of physician health. And of course, that's extremely important, but we all know it's bigger than that. Over the 90s, what then started to emerge was, mental health being a very real and important issue for physicians. And, how do medical schools look at that? And how can curriculum help promote good health of medical students? And how can we use that to build a more vibrant profession? In the early part of this century, behavioral issues started to get woven into this, and we would think a lot about quote unquote disruptive behaviors and things that could be problematic at work, and then sort of the brakes got put on that pathway of nomenclature and a real shift from thinking of physician health as focused on either individual illness and impairment or things that weren't healthy, but actually thinking of physician health as physician wellness or well-being. And trying to move the whole canon of effort and work away from illness and impairment, and thinking about, let's think about quality of life. Let's think about population that can be free of the being. How can we think about building systems that promote physical health? How can we build a community where we really are socially integrated, where we support each other, where we're really helping each other thrive and develop our full potential. It's a dramatic and important shift in language, and one that I think is, I certainly think it's the way to go. Lots of researchers have picked up on that word, thriving. And I think many of us at the end of a busy day might go, really thriving? I'm kind of tired. I want to get home and get to my kids and just have some peace and quiet. And really what the literature is saying, we can build a sense of thriving by really leaning heavily in the relationships in which we work and learn. And just to nod back to Horst, your land acknowledgement includes a acknowledgement of play. And that fits beautifully into the evidence around relationships as being a source of resiliency. So a question is, who's your community, and what are your relationships like with the community, and how do you build and feed them, and how are you fed and nurtured in them?
So Derek,
yeah,
just a question here,
yeah.
a comment. I noticed I spent years working in rehabilitation, and the thing that I've noticed significantly in terms of who goes home and who goes to long-term care is essentially the social support network
Right.
of that individual and the tightness of that social support, regardless of the extent of the stroke or the injury. So, when I start looking at burnout, having been a physician who's experienced burnout, uh, one is it's a very isolating experience. You actually feel you're not connected to people. The other one is the loss of control in terms of that your decisions being able to affect change. And the last thing is the efficacy of what you do seems to become less meaningful over time.
Yeah.
I wonder if you had any comments in terms of that.
Yeah, for sure. I think a lot about working Emerge. I'm working psychiatric Emerge, and talking to the team about how do we understand the story of this person, and as we build a realistic and safe discharge plan. And it often would, our first thoughts would be, well, who's their community? Who's their social supports? Where are they going? What does that look like? So certainly in my own discipline, that resonates a lot. And I think in some ways, what a lot of nimble organizations are doing, learning organizations lean heavily into the notion of relationships, and building systems using relationships as opposed to transactions to build systems.
Yeah.
Again, I think back of our conversation the other day, Harsh, and I said, we were talking about crafting, and I said, if the notion of making a sweater for someone you love is the ultimate sign of caring and nurturing and respect and connection, how can organizations knit sweaters? What does that look like at an organizational level? So anything that helps us feel integrated and connected is so important.
And I think that ties back in with when we begin with our First Nations acknowledgement. The First Nations foundational concept in wellness is actually the relationships, and building communities.
Yes. And it's I think that it pivots. It's a great thing for us to learn, observe, and experience on a nation-to-nation level, because it is just so practical, isn't it? Yeah. And if I sort of nudge us in this direction, when I think about moral injury, everything we've learned about moral injury comes, I think, from two large communities. I think nurses have been talking about moral injury for decades. They have a rich literature about this, and really thinking about how how the demands of the system and the moral code of the individual can be under tension. And sometimes that tension gets to a snapping point and can really bring harm. The other community that speaks a lot about moral injury are soldiers, and a very rich literature about moral injury. When I think about how this could affect us in our practice at a community level, you can think about at a community level, how do we experience things like sorrow, grief, regret, all the way to some of the symptoms that can happen when we're under stress. So I think it's important for us to think at a systems level about what happens to us that can be morally injuring, and how that can affect us individually and in teams. The military community has gone even further. They've developed, I think, very rich constructs of resiliency, thinking about mental health continuum, and looking at, how do we help people achieve optimum mental health well-being? How do we put that as the goal, as opposed to building systems primarily focused on managing mental illness or unprofessional behaviors? When I was working doing consulting work at Royal Military Academy in Kingston, I had an opportunity to work with young people, sort of 16 to 21, who were being trained as officers in the Canadian Armed Forces. And in some ways, my job was made easier because they were all trained in this model, this mental health continuum model, where it was normalized. From the very beginning, they were taught, look, taking care of yourself and being resilient doesn't mean being resilient all the time. It's being more connected and mindful about where you're at. So there's going to be times that you're going to be very healthy. There's going to be times that you're going to be under stress. You're going to be reacting to things. And then what we want to help you with is how do we, as a system, prevent you from becoming injured or ill? But also, how do we help you recognize when you might be becoming injured or ill? And how can we either prevent or intervene with that? And I used to love it. I would have young people come in and I'd say, so what brings you to see me today? And they'd be like, you know, I'm in the orange. I'm in the orange and I don't like being in the orange and I want to work on that. And there would be times that at a systems level, we'd hear, you know, leaders, either academic leaders or military leaders saying, you know, I've got a group of young people and I see that they're really in the yellow. We need to look at that. What can we do to manage that? What's contributing that we can fix? So I think being aware of these models at a systems level can also be very helpful. And I'll just give a nod to two systems, and then we can, I'd love to hear from the audience and of course from you, Harsh. You know, the Canadian Mental Health Commission has done a great deal of work looking at standards for psychological health and safety in the workplace. And I bring this up because it's very much a positive framework that helps us acknowledge and build resiliency right into the system. How do you bake it into the organization? So really our systems help our people thrive. So I just wanted to give a nod to that. And systems such as, you know, Leads Canada, which looks at leadership competencies in the health sector, have built a lot of systems around this framework. So I think all of this to say is that there are current resources that exist that organizations can use to build psychologically safe workplaces and promote resiliency. So yeah, I'll sort of I'm going to flip through two things and just sort of land here, and maybe some things for us to consider with the group. You know, what is our relationship with resiliency? What does that look like? What does that mean to people? Why is it important to your health authority? What are some of the ideas towards change that people think about? How might we create positive change in this space that's real and practical? Who are the collaborators? Who are the partners? Maybe I'm thinking people who might be within the community, and then of course people within the system. How do we explore that? And of course, as individuals working within a system, who can we lean on for support? So happy to discuss that, but maybe I'll sort of pause the formal presentation there and we can get back into a conversation.
So you could raise your hand or put in a question through the chat, or simply hit *9 on your phone and connect and we'll take your questions. A lot of talk in terms of resiliency is sort of being focused on what I call the hammer and the plate. The plate is the human beings inside the system. And the talk has been, well, this is your problem. You need to become resilient. So if someone produces a, how can I put it? There's a little handout, here's a PDF, etc. You figure it out. I want to put out to you, what are the system's responsibilities? And the system contains, the environment contains the conditions and sets the expectations for individuals.
Yeah, you know, I think for a long time the focus in this space was on the individual, which I think for a lot of people may have stung, you know, and often I'd hear people talk about, you know, you're just going to tell me to kale. And you know, you just want me to go for a walk, and it's really not about kale and a walk. I work 12 hours a day, and I haven't had time to spend with my kids. Or the demands of my hospital have completely sabotaged my relationship with my family, and my spouse has now left. So I think putting too much emphasis on the individual is actually quite harmful. I think acknowledging the power of the individual and empowering people to explore their own relationship with resiliency is really important. And I think teaching people at a very early stage about their relationship with their own occupational health is important. And then creating safe spaces for people to go and to take care of that. The flip side to all of that is what do we do as a system? So I'm always mindful about what are the accreditation standards that are specific for physician health and wellness. So what's on the table and how do we evaluate those things? What do we do if a system is struggling with toxicity in the workplace? There's a lack of trust and social support, so people aren't being maintained or sustained or moved along in their experience of practice. What do we do with that? So I think looking at those systems level issues is incredibly important. And again, the nod back to the Mental Health Commission of Canada, acknowledging that having psychological standards of safety in the workplace is truly important. Yeah, so those are a few thoughts.
So Derek, what's being done, Shirley asks, what's being done at the system level to prevent disposition of disease and that psychological safety, creating that?
Yeah, it's a tough one because the system is so complex, eh?
So take, for example, with the college itself, because I know when you get a complaint, you get a heart sink moment and this mental image of auditors going through every single chart, every sentence that you've written, and feeling that sort of feeling of suspension and rethinking, going over, did I miss something?
So true, isn't it? I think everyone works so hard to do what's right. And if I think of how some of us may have been socialized in the area of reflective practice or, managing an error or dealing with a complaint, not all of us had that as a positive experience. Shoot, I remember at one point in training, I think I had the landmarks of the right lung mixed up. I was like flustered and I screwed it up, and I got kicked. That was how it was dealt with in front of my colleagues. I was kicked, and you're stupid, and you should know this. And I'll tell you, the next day I knew my landmarks, but it did leave that imprint of this is what we do when we're confronted with error. We go to a place of shame and panic, and we expect to be hurt. I think looking at how we really normalize talking about quality and safety in our practices is going to be a big part of that. How do we acknowledge that so much of the work we do in regulation is focused on building standards to promote safety, taking remediation and remedial approaches is generally the way to go. How do we have the right touch with our approaches so that we build a system without traumatizing everyone within it, while at the same time maintaining our laser-like focus on public safety. So in my mind here, at the college, I think a lot about how do we humanize our processes for all parties, and what might that look like? It could be something as simple as when we send out a letter, maybe we don't send it out in a color that is triggering for some people, to reminding people up front that this may be stressful, and here are places you can go to for help when this is stressful, such as the Physician Health Program in British Columbia. Anyway, those are just some thoughts first.
Okay. One of the things you alluded to this, I've experienced it. Our residency programs can set us up in terms of expectations and the imposter syndrome, which usually is the first 5 to 6 years of medical practice before you realize you're not alone in this endeavor. Have you noticed a change in the way we're training residents or giving them the tools or role modeling for them?
Yeah, a couple of thoughts. I have a deep appreciation for CanMeds and the CanMeds competencies. We were able many years ago to squeeze in physician health into the professionalism role, partially because we wanted to have standards that could be used to advocate for systems change. So I do think we've got fabulous educators doing work to train people differently. But I'll tell you what really gets me excited. I'm genuinely excited is we've got beautiful, remarkable, mature, creative residents and medical students who continue to stretch the profession. Earlier this summer, there was an article published in a procedural journal looking at social media use by residents and medical students and how unprofessional it was. And they pointed to things like, residents posting pictures of themselves at the beach, like maybe they'd be in a bathing suit, or maybe they'd be wearing a rainbow flag, or a fist symbol. And all of that was pointed to as demonstrations of lack of professionalism. And I was just so impressed with the groundswell of very respectful discussion about that, and people talking about how you can be professional and be very human. And it just gave me a sense that, you know, there's parts of the system that are in really good shape. So we need to continue to listen very carefully to students and residents. They've got very wise things to say.
I know that Paul Dagg, who's one of our mental health leaders in psychiatry, often talks about creating the environment that's safe enough to say, I'm tired and can you keep an eye on me? And that can actually be a more humanizing way of managing fatigue than simply trying to motor through and hope nothing untoward happens.
Yes, yeah. You know, I could probably ask people to close their eyes and think about who had the biggest influence on your professional life, and you can probably all think of some pretty amazing people. I think of one of the chairs of my department, and we were struggling a lot. You know, sort of the maybe starting about 7 or 8 years ago with the rapid escalation of presentations to the emergency room of children and youth in crisis, and we used the word pandemic back then. I mean, we would kind of go from seeing 5 to 7 kids a night to maybe 7 to 15 to then 15 to 20, and people would come to our MD groups just saying, "Wow, it's really busy, it's really hard," and our leader looked at us and just said, if you're overwhelmed, why don't you just call each other for help? And it created this sea change in time moment of just acknowledging that we, you know, in that space, we are very much an occupational family, and we ought to feel comfortable sending up the red flare. We're overwhelmed, it's no longer safe, I need help. And it was really quite liberating for us. Really helped us just openly talk about how exhausted we were. And let's build a different system to manage that.
And I see that happening, especially in COVID, with the use of things like WhatsApp, Slack, etc., to create communities of keeping in touch. As long as we don't share personal patient information, etc., that's all perfectly fine as long as people are respectful. Sean asked, during COVID, it's been easy to see colleagues who have low resilience. How do you help a colleague who you see has this poor resilience? You notice something.
Maybe we could do this in 2 ways, Harsh. I might invite participants in the call. Put your thoughts in the chat box or Q&A box, whatever it is we're using to harvest advice. Just fill it up with how. I'd ask you 2 things. How do you like to be supported? And how do you support your colleagues? So maybe just populate the box as we're talking. And I often think, Harsh, sometimes the best thing we can do for each other is simply be present. I think as physicians, we've got such big hearts. We care so much. And we're fixers, right? Like we really like to get in and solve things. And sometimes when our colleagues are approaching us with issues, it's almost like the last thing they need is for us to sort of have our white coat on. It's almost like they just want us to be there to sit with us and maybe just listen and acknowledge that you know, this is a condition of suffering, and this is really difficult, and I'm just here for you in this space. And often individuals will start to solve their own ideas or come up with what's going to be helpful for them when they feel safe and supported, and then we can be present with them if they want us to be. The other thought is again, on an individual level, we can think about just having a pocket card of places to go. I always think of the Physician Health Program at BC, and it's a wonderful organization with great people. But also, like in your community, what would you want in your community? Who you know, how do you prep your leaders to do this work? How do we prep each other to be good peer supporters? There could be lots of fun things to build.
I know in Ontario they talk about the OMA about having a buddy system, you know, or having a coach or a mentor or someone that you can just say, this is how I'm feeling. I don't need a solution, right? So one of the lines is, do you want advice, or do you want me to try help you solve this? Do you want to know where to go? And those become the three things that the coach or support keeps in their back pocket, and that's how they frame the conversation.
It's so true, Harsh. And, like sometimes you just need someone to be with, so you actually can kind of not have your white coat on. You can rage, you can vent, you could cry if you need to cry. Like you could just be what you need to be in a safe way without repercussion. And that's a really kind thing to do. So I can't see if people are populating anything in that list, but I don't know if there's anything that
we have a raised hand. Dr. Dodd?
Well, thank you very much. Fascinating conversation, and really appreciate you taking the time talking to us about this. I'm always interested in your comments around physician burnout, and it's something we struggle with. And I was actually a bit surprised when you mentioned that it was the younger physicians and those that are earlier in practice. I think I got you correct in saying that they were more likely to risk or discuss burnout, whereas I would have almost anticipated the opposite end. Is that because, in your experience, you found that the younger physicians are more willing to talk about it, whereas older physicians, we may be trained. I'm an older physician, so we may be trained in a different time, in a different era, where we really didn't admit to any of our weaknesses or insecurities. That was a negative sign we didn't want to show. Just curious, how do we reach out and create a positive space for those older physicians to discuss this and be open to discussing this?
I really appreciate your observations, Graham. And I think you're onto something really important, because a one-size-fits-all approach really doesn't work in this space, which probably doesn't surprise us, right? If I think of strategies that have been really helpful to listen to and nurture, conversations with folks early career, they're very different than what we may use with mid or senior career. And so I often think with people who, let's say, are more senior in their career, often the preferred approaches are more individualized, which I find interesting. So less comfort with being open with issues in a group. So that makes me think about, how do we create multiple pathways to support for people? So is it going to be mentorship with a chair? Is it going to be some sort of safe space with one or two peers? Family medicine has a rich history of Ballant groups, for example. So really thinking about how do we respect that, perhaps a more individualized approach. And then on the flip side, I think about, how could we radicalize and disrupt that space and have people who are in that phase of career actually put things out on the table and talk about their own experiences and perhaps renormalize or newly normalized approaches to health and resiliency. And I've seen that work beautifully for some hospitals and communities. So all that to say is, I think what you're saying is really important.
Great, thank you.
Derek, Sean asks that the military often deliberately places people in situations that could be quite psychologically damaging, not dissimilar to being a physician in some ways, particularly during training. Mm-hmm. How does that approach reconcile with a supportive system?
How does that reconcile with a supportive system? Interesting. I'm not too sure I'm appreciating the full nuance of your comments. So I'll throw something out and then I'll shut up and you can let me know if I've got it. What I would observe in the military system was, of course, experienced through my patients, but appreciating that the end goal was to prepare them to really take a bullet for us. And of course, so much more. And so their training had that end goal in mind. So the exposure made sense, and the exposure was connected to a reasonable outcome. I think in medicine, we need to be mindful of the positions we put people in and think about the end objective. So if I bring in moral injury, I start to think about, we may put people in a position that's really not necessary, that may be economically driven as opposed to relationship driven, and it creates trauma that's not related to an end goal. And that's where I see things start to separate. I don't know if I'm tapping into the gist of your question, so I'll stop talking.
One of our physicians asks, what a big issue is work overload, just simply the amount of work, and that the best thing anyone can do is give you a couple of hours to take over some of your work so that you can not have to be there for 10 or 12 hours at a stretch to just even catch your breath. But that's hard to do when everyone is over in your department or area feels overloaded. Any practical suggestions on managing that? Because that's, you know, finite resource in an infinite demand environment.
I do, although I don't have many easy ones. If we look at leadership literature, we know that there's a correlation between leadership success and the percent of professional time that is spent in reflection. Okay, that's clearly established. We can also start to pull data from surveys from, let's say, Fortune 500 companies, and I'm not saying that's us, but I'm saying that there's some lessons there, where senior leaders in that space often have 20 to 40% of their schedule protected for reflection. That's not going to happen for us, right? But what I do wonder about is the value of protecting regular time in our schedules to have some reflection, and that might come at a cost. So it could come at a practical cost, like, you know, particularly, I remember my fee-for-service days, so it means that, you know, we're not getting paid for doing reflective practice, and how does that, what are the trade-offs like for that? And then also working with leaders and systems. So when we think about our accountability data, how do we build in recognition for time spent in reflective practice and have that count towards our accountability data at a systems level? So that's a direct challenge to, you know, sort of leaders and auditors of that system to recognize A, that that's important, and B, it has worth.
One of the things identified is, how do you go about identifying what you can control and what you can't? Because there's an overwhelming feeling that a lot of things are beyond your ability to affect.
Yeah, you know, if I was standing, I would stand up and I would be drawing a little box around my space on the planet, and I would say, this is kind of what I get to control, except there's a whole lot of genes that I don't get to control either. And there's just something about that for me that just reminds me there's just so little we've control over. So what do we have control over? We have control over how we nurture ourselves. We have control over our sense of hydration and nutrition. We have control over the priorities we make in our life around social connection. We have control over taking 2 or 3 minutes at the beginning of our day to have a look at our schedule and ask ourselves deep questions like, what's my intention for today? You know, what am I bringing to this that I really want to show? We have control over, you know, shutting ourselves up when we're beating ourselves up, or getting help for that if it's too hard. And we have control over asking people for feedback. And I suppose tapping into something that I heard earlier, Harsh, we have control over the choices we make to make connections with people. I'll tell you, having lunch with your colleagues as a physician is probably one of the hardest things you'll ever do. And isn't that interesting, right? So again, we can have lots of conversations over what we can control and not.
So, Derek, I think we'll wrap things up, and I really want to thank you for participating in these rounds. Any final thoughts? I mean, the question that comes up, where are the resources that we need to be able to do this?
Yeah, you know, I'm a big believer that the biggest resources come from within the community. And if you come together as a community and you start to ask yourselves these questions, what is our relationship with resiliency? Okay, let's really, what does that really look like? What resources would be helpful to us? Where could we get them? And what are the big things that we'd like to change? And how might we do that? Then you get the discussion going at a community level. There are so many resources in the resiliency world. The Canadian Medical Association has a beautiful hub summarizing lots of research studies and resources and literature lists, etc., on physician health and wellness. So I'd encourage people to check that out. I push organizations pretty hard to think about using competencies to guide leadership development and training. So LEADS gives us a sense of those. CanMeds gives us a sense of those. And some organizations are going as far as to have, at the executive level, a medical officer whose job it is to solely focus on the wellness of the people in the system. So lots of ways of unpacking resources. So hopefully there's something there that will be helpful.
And I just want to remind people that as we were preparing for COVID, doctors are having more conversations in the future, I am sure.
Well, thank you for inviting me to be part of your community today. Take care, everybody. It was nice to virtually be with you.